Good afternoon, everyone. My name is Melike Harfouche, and I am an assistant professor of surgery at the University of Maryland School of Medicine here in Baltimore. Oh, Seema, you're muted.
Sorry about that, everybody. I'm Seema Anandalwar, and I'm one of the second-year fellows here at Shock Trauma.
We will be your co-moderators here today for this talk titled Hemorrhage Control and Pelvic Fracture Management, Everything But the Kitchen Sink.
Before we start, just some housekeeping. Please note that AAST no longer offers CME for live Grand Rounds. Should CME be available for the archived version of this Grand Rounds, those who watch today's will receive an email once the archived version is available on the AAST website.
We have an expert lineup for today's Grand Rounds. We have Dr. Toni McLaurin, who is a professor of orthopedic surgery at NYU Grossman School of Medicine and the chief of orthopedic services at Bellevue Hospital. We have Dr. Burlew, who is a professor in the Department of Surgery / GI, Trauma, and Endocrine Surgery at the University of Colorado. And we are hoping that Dr. Joe DuBose can join us. He is currently stuck in the operating room, but he is a professor in the Department of Surgery and Perioperative Care at the University of Texas at Austin Dale Medical School. We're going to start off by having each of our speakers give a 10-minute presentation on their area of expertise. Once they're done, we'll continue with two pretty complex case discussions, and we'll pay attention to the chat and try to answer or have them answer some of your questions as we go. And if there's some time at the end, we'll really focus in on the chat questions. So please go ahead and put those in there. We're hoping to really have an engaging discussion at the end. All right, without further ado, Dr. McLaurin will start off with her presentation.
All right, so I'm going to give two disclaimers at the beginning here. First is that I tend to talk really fast and talk faster as I know that I'm pressed for time. And the second is that I have 10 minutes to talk to you all about what has taken me over 30 years to learn. So it may fly by. Hopefully we can have some opportunity to ask questions at the end. And also I apologize when I go over time a little bit because I'm sure I will. So hopefully not too badly. All right, so I'm going to talk about pelvic fracture patterns and early stabilization. And get my slides to move. There we go. And so the most important thing here is just recognition. You got to make sure you recognize which are bad ones, which are not, assess them appropriately, know how to classify them so you know what you're looking at. And mainly to do that is you want to do that in order to identify patients at high risk of hemorrhage and mortality and figure out what are the most appropriate early interventions. So this really all starts with the physical exam. The minute these patients present, if you see lower leg deformities without any obvious lower leg injury, think about a pelvis fracture. You see this guy on the right here, he's all splayed out, and that's because his pelvis is wide open. So if you see a limb length discrepancy, so that would mean a pelvis that shifted proximally, that might, and you see nothing obvious in the legs, or if you see excessive external rotation like this, you need to start thinking right away about the possibility of a pelvis fracture. And so this is what you got, and that's why he's so rotated out there. So the AP pelvis is supposed to be part of ATLS protocol, and it doesn't always happen, but we really like it to happen because it can give you a lot of information. Afterwards, we like inlet and outlet views, but these are not nearly as necessary. And then, of course, a CT scan. 3D reconstructions are more for operative planning, but the three different views, axial, coronal, and sagittal, are essential to really understand what's happening. And just getting a CT scan is not enough. We need the x-rays as well because we don't have a CT scanner in the OR. So we need to know when we're fixing these, what it is that we're looking at. So on an AP pelvis, like I said, you can get a lot more information than you think. So I'm just going to systematically go through this and show you. So here's an AP pelvis. And so there's your sacrum right there. Here are the iliac wings. That's the posterior superior iliac spine in the back there. And this is important for how you look at this. Here's the iliac side of the SI joint. So that's not the sacrum. Here's the S1 sacroiliac, so you see how they overlap there. And so when you're looking at a CT cut, because this whole joint, the SI joint, is oblique like this is the block that you're seeing on X-ray. So you're seeing the overlap of the sacroiliac, the SI joint, and the iliac side of the SI joint. So that's important to think about that when you're looking at these. So you can use this to evaluate displacement. So if we drop a line down the middle of the pelvis, what you want to, and then put another line across the tops of the femoral heads here, and then you look at, these are the ischial spines. So those are posterior structures. So those will change depending on the rotation of the pelvis. And then you look at the distance from the midline to the iliac side of the SI joint, because remember the sacrum is not necessarily going to move. It may with a bad pelvis fracture or sacral fracture, but usually it's the iliac wings that move. So here's a wide open pelvis right here. So there's your, you always want to look for the spine, make sure it's not rotated, because that will also give you a false view of your x-ray. And then there's your sacrum. And then that's the medial side of the joint. And then if you outline these two iliac wings, you see that they look very different in shape. And that's because they're rotated. And then that white line right there is the iliac side of the SI joint. So you see this huge space right here. You also see, obviously, the symphysis is disrupted. That's much more obvious. And then if I drop my midline, if you notice on the ischial tuberosity or the ischial spines here, the one looks like it did on the AP pelvis we looked at initially, and this one you're seeing a lot more of it. So what this tells you is this entire hemipelvis on the left is massively externally rotated and disrupted and translated. So you see the two red arrows showing the huge difference in the distance from the midline to the iliac side of the SI joint. So we just got all of that off of just this one x-ray. And then we can also see that there's displacement in caudad cephalad, because again, here you see that this line drawn across the top of the femoral heads is not touching both of them. So here's the inlet view. You get it by tipping the beam like this. And basically it shows us a lot of things. The most important thing initially is just that it shows AP displacement. This is the outlet view here. You get it the exact opposite way that you get an inlet view. And this shows us cranial displacement. So if one hemipelvis is up higher than the other. Don't forget to look everywhere when you're looking at these x-rays, because we're focusing on the bones, we are, but you can also look at this and see things. So if you notice right here, that's the bladder filled with contrast right there. Obviously, that's not the normal shape of a bladder. And it's also massively pushed over towards the left side. This tells you there's a huge pelvic hematoma in here that's disrupting the bladder. The other thing you see also is that is actually contrast coming out of the bladder. So here you've got probably a urethral injury and a massive pelvis hematoma. So even though this x-ray doesn't look terrible, you know that this is a bad pelvis fracture to have caused all of this stuff to happen. On the CT scan, this helps you confirm what you're seeing on the x-ray, and also is good for posterior structures that they're easily missed on plain films. And you can see the neuroforamina. If you notice this one here, it's kind of crunched a little bit. That can be significant if you have a patient with a neurologic injury on that side. And then even without a CTA, you can actually see contrast extravasation if you've got a CT with contrast, and that can help you identify an active arterial bleed and identify the pelvis as a source of hypotension. And then this can start you down your decision tree. So when you look at the fracture patterns, they can be a combination of bony or ligamentous injuries here. And we're talking today about high energy injuries that are anterior. So you're going to fracture the pelvis both anteriorly and posteriorly. And so we like to think about it like a hard pretzel. So if you try to break a hard pretzel in one place, it will always break in two places. That's a young person's pelvis. Not to be confused with a soft pretzel. This is an elderly pelvis right here that you can pull apart in one place and the rest of it stays intact. So these are two very different injuries. So this is not what we're talking about today. And so then we need to classify these things. So there's two main ways to do it, either by stability or injury mechanism. And even though the stability one is the one used more often in journals and studies and things like that, the injury mechanism one is the language that you're more used to hearing. This is important because you can use this to predict the need for early intervention and also to predict associated injuries. So these are what you get. You get AP compression. So that's when the pelvis is kind of squished. That's an external rotation injury. Lateral compression is an internal rotation injury. So people who get like a T-bone car accident, you're going to get pushed on the side of your pelvis. The hemipelvis is going to rotate internally. Vertical shear happens when one side of the pelvis is stable while the other side gets pushed. So someone who falls from a height and lands on one leg is going to get a vertical shear. And then there's something called combined mechanism injury, which is just a mess. We have no idea what it is. And it's just a little bit of everything going on. Then each of these is subdivided, and we won't go through this in detail, obviously, but with the APC injuries, it goes from 1 to 3, with 3 being most severe, and it results in a lot more soft tissue injury, a lot more ligaments torn between the sacrum and the rest of the pelvis, and so that's going to make it much more unstable. In an LC injury, they also go from 1 to 3, again, becoming more severe as you get more towards the 3 side of things. And a 3 is actually a combination of an internal rotation injury on one side and then an external rotation injury on the other. So that'd be someone who gets like run over by a car. So one side of the pelvis gets internally rotated while the other side gets externally rotated. And then a vertical shear, as I mentioned before, you get a vertical force on the pelvis. And so you're going to get disruption both anteriorly and posteriorly. These are very unstable. You can imagine what it takes to make one side of the pelvis sit up this much higher than the other side. And if you look at the 2 iliac crests right there, you see how far off they are. And you can appreciate in the sacrum, this is half of the sacrum up here. The rest of it is down there. So there's a huge, terribly displaced sacral fracture going on here. Oops. And then this is the combined mechanism. And again, like I said, these are the ones, they just sort of a little bit of everything going on. These are obviously very unstable injuries. So with the APC injuries, it's important to recognize them because the things that are associated with them are brain, abdominal, visceral, and most significantly pelvic vascular injuries. They also have an increased incidence of shock, sepsis, ARDS, and death. So these are the really bad actors here. With the LC and vertical shear injuries, your associated injuries tend to be more brain and visceral, so less of the bleeding associated with this, and a decreased incidence of the bleeding, as I mentioned, and the other associated complications, because these more happen from getting struck on the side or somebody falls and lands on their side. So why do these patients die? Why are pelvis fractures such a big deal? With the AP injuries, it's usually the combined effects of blood loss from the pelvic vascular injuries and the visceral injuries. Lateral compression and vertical shear patients actually tend to die from their brain injuries, so not related to the pelvis. So what gets us excited? These guys over here. So the LC3, APC2 and 3, and the vertical shear and combined mechanism. So things that are unstable, those are the ones we need to look out for. And this is why. This is an older slide. So fortunately, we've gotten better with our resuscitation. But you can see as you sort of march up the ladder of severity, how much more blood requirements there are within that first 24 hours. It also affects their mortality rates. The higher the energy, the higher the mortality rate. Makes perfect sense. And you see these still, even as good as we've gotten in managing these, they still can have a really high mortality rate. And if it's open, that's over 50%. And so in the first 24 hours when people die, they tend to die from the blood loss. After that, it tends to be more related to multi-system organ failure. And why are they bleeding so much? Well, they bleed from the fracture surfaces. These are big bones that you break a bone, bones bleed. They also the presacral venous plexus. That's important to remember that this is venous, not arterial. You can have local arterial injury, tends to be the superior gluteal artery, which you see comes off here and goes right through the sciatic notch. So you can imagine there's your SI joint right there. So you can imagine any disruption to the SI joint puts this at risk. Major vessel injury, you don't see much because this is going to be the iliac vessels. And so if somebody has that from a pelvis fracture, they're likely to exsanguinate on the scene. So that's much less likely. So what do we do about this? So you need to decrease the pelvic volume in order to control the bleeding because volume is related to the radius cubed. And so you can help to tamponade it by not giving it as much space. And you also want to decrease the motion at the injury sites, and that helps to prevent the clot disruption. So the easiest thing to do first to decrease the volume is put a binder on the patient. And we all know about doing that. Traction also, when you have these vertical shear injuries like this one here, with the pelvis up like this, if I just pull traction on it, that will take a lot of the shearing off of the vessels back there. And then external fixator, C-clamps, and then you're going to have separate lectures on these preperitoneal packing, angiography, and REBOA, which is good because I don't even know what that stands for. I know it's useful, but I am not the one to talk about that. So the big question you have to ask yourself is this injury stable or unstable? If it's unstable, then what? You need to make it stable. So that's your job. So the binder is technically called a TPOD, trauma pelvic orthotic device. That's where that came from. It's a very powerful tool. You can see this is truly the same patient, wide open APC3 pelvis. And then here, you could almost mistake this for an APC1. This is important that you recognize this and you notice if a binder is on or not, which you can see on the CT scan here, because if you miss that and you think that you can underestimate the severity of a pelvis fracture without recognizing that the binder is on. And also know where to put it. It goes over the greater trochanters. If you put it any higher, it doesn't do the job that it needs to do. So make sure it's getting put in the right place. And then again, as I mentioned, you'll get separate talks on angiography and embolization. These control arterial bleeding. So keep that in mind because it's mostly venous that we're dealing with. And then I can just put in a plug as an orthopedic surgeon. We don't like embolization if it's not necessary, because if we need to operate, you knock off the blood vessels or blood supply to our soft tissues, and we end up with things like this. So we don't like that if we can avoid it. The X-Fix controls an anterior injury well, also allows access to the abdomen. We use it much less commonly now because people get put in binders and then we can fix them relatively acutely. Be careful though, it can worsen a posterior injury. You can imagine if you put an X-Fix into this iliac wing here, and you try to close it down, you're basically just going to crank it open in the back there. So you need to understand the pattern that you're dealing with before applying the X-Fix. Something like this is clearly not going to work because the iliac wing is not even in the SI joint. So this is going to do absolutely nothing for you. There's a thing called an internal fixer. I'm not really going to talk about this. It's just X-Fixes have problems with pin sites here. The infix is basically the same thing. You just put a metal bar under the subcutaneous tissue. So as you might imagine, patients love it much better. Nurses love it. So you end up with this as opposed to that, but same concept. It's helpful if you're concerned about, any internal fixation, the internal hardware with such as bladder injuries, or if you've got a bad subcutaneous degloving, a Membrella lavalae. But I think they're already starting to fall out of favor because there are, as you might imagine, some complications associated with it. The C-clamp, there's two different types of them here. This is much more common in Europe, and it's very center dependent in the US. There's some centers that use them. Most people do not. And basically it goes in the posterior pelvis, and you get these two pins that go in here. So you can imagine for this particular pattern I showed before, this would be perfect because it would push that in right from the side. And this is what it looks like on, and then you can flip it towards the head to access the groin. You can flip it towards the feet to access the abdomen. So it can be helpful for multi-services. This is what it looks like. Again, a very powerful tool, closes down this APC, but also a very dangerous tool. If you miss, your x-ray might look like this. And whether this is anterior or posterior, this is not where you want a sharp, pointy object. You can also make your pelvis fracture much worse. This is way too anterior. This should be stabbing way back here. So don't be that person. As I said, again, you're going to get a talk about this pre-peritoneal packing. The one thing I want to put in here from the ortho side, the pelvis has to be stabilized prior to packing. If not, you actually can worsen the disruption and end up with more bleeding. So it needs to be a combined sort of thing going on. And here's just a diagram of what it is. And you notice right there, it says pelvic ring stabilization, then PPP. So just keep that in mind. The main point is that pelvis fractures kill people. And so these can be very terrible things. So you want to make sure that you're examining the patient, you're getting the x-rays and looking at the x-rays and CT, and that early assessment matters. You want to identify your high-risk fracture patterns, apply the binder early, exclude other sources of bleeding. Don't be just, distracted by the pelvis fracture, and understand that you got to look for other stuff. And ongoing resuscitation, obviously warming of the patient. So this is basically, you want to resuscitate, coagulate, tamponade, and then if all else fails, then you can move on to angiography embolization. And then ultimately, we want to be able to fix it and make it pretty like the one on the bottom there. All right. That is it.
Thank you so much, Dr. McLaurin. That was fantastic. I think our knowledge of orthopedic trauma as trauma surgeons is insufficient, and I love having you here to kind of help grow some of our understanding. And I have so many questions, but I will leave them to the end.
Right. I'm ready. I'm always happy to help.
Great. So next we're going to have Dr. Burlew talk to us about preperitoneal pelvic packing.
All right, am I getting close? Does that look okay? All right, perfect. Thank you, Toni. Sometimes you always wonder whether or not your slides are appearing exactly the way they're supposed to, or if they've got an ancillary screen up. So In following Toni's lead, I am also going to try and speak quickly to sum up what is basically a 30 or 45-minute talk into 10 minutes. So I'm going to try and just really touch on the indications and approach for pelvic packing this afternoon. And I have no disclosures. As she has already highlighted, we recognize that the vast majority of our pelvic fractures are really stable and low energy mechanism. And so it's really this very small subgroup that does poorly. These are the patients that have a high mortality rate and high complication rates. And when we really look at the overall number, this is probably about 6 to 8% of all pelvic fracture patients that come into our trauma bays. Now, when we talk about fractures, we can either talk about it as mechanisms or energy, or as a trauma surgeon, we like to see from the standpoint of mortality related to the impact of red cell transfusion. When we look at mortality in pelvic fractures, as mentioned, about a third are due to head injury, a third due to early bleeding, and a third due to MOF, which is probably also related to the impact of red cell transfusion early. As you see here, the number of red cells, as we increase in number of red cells, the increase in mortality is concurrent as well. And so as you begin to pack or stack all of those red cell units that you see on the floor there one day in the trauma bay, our goal is to stop the bleeding in these patients. And so addressing the early sources of hemorrhage in these complex trauma patients is really important. So I'm going to talk just about the nuts and bolts of how you pack a pelvis. So we in Denver started packing pelvises back in 2004. So it's been about 20 years now. It was originally described in Europe, and it involved rapid transport to the operating room, external bony fixation, and then packing of the retroperitoneum. Now, we modified the approach slightly so that it's really a suprapubic approach to addressing packing within the preperitoneal and paravesical space. And the rationale, again, is because the vast majority of bleeding is venous and bony in origin in these patients, at least 75% based upon classic studies. It really is addressing that source of bleeding. And then you're also already in the operating room, and these complex patients, often about 85% of these patients, need something else done in addition to just their pelvic fixation and their cessation of hemorrhage. So when we do this, we always start with pelvic fixation first. Here you can see our orthopods were kind enough to zip on in, and it takes them probably a whopping 5 minutes to put their external fixator on. And I think the key is that as the trauma surgeon, you want to make sure that you are part of that conversation. I learned my lessons sometimes the hard way, which is not being part of the conversation or not paying attention early on. So if you are only planning to do pelvic packing, you can place the bar, those cross bars, high up over the umbilicus in the patient and have nice access to the preperitoneal space just in a suprapubic incision. However, if you think you also need to do a concurrent laparotomy, or you're not sure after your laparotomy if you need to do pelvic packing, always put that bar low. And so that way you have access to the entire abdomen should you need to take care of things. Now, once you have your bar in place, and you can see the bar was placed low down over the pelvis, the pubic symphysis here, you then do a 6 to 8 centimeter incision. This is done directly from the pubic symphysis cephalad, and you divide the midline fascia, split the muscles, and you can see the bulging of the pelvic hematoma. And this is the point which, for whatever reason, all of us who have trained to never touch the pelvic hematoma, I am now telling you to jump right in there and dive into the pelvic hematoma in order to stop bleeding. And so what can happen when you do this is as soon as you basically put your hands into that space, you're putting your hands into the hematoma, which has nicely dissected this paravesical space, for lack of a better way of putting it. And so what we simply do is I tend to put my hand straight in. I put my hand on top of the bladder, or sort of the side of the bladder. I pull the bladder over towards me, and someone else is using a small rich to hold the incision open. And then we're going to put 3 lap pads around the side of the bladder. And that first lap pad is all the way down onto the presacral space. And so my hands aren't big enough to get all the way down there. So when we do it with our orthopods, sometimes they'll use a Cobb elevator to put that last pad all the way down there. I like to use just a ring forceps to put that first pad all the way down there. And then the second lap pad is up lateral to the bladder, and the third lap pad is up sort of anterior. And then we flip and we do the same thing on the opposite side. Hand on the opposite side, pull the bladder over, first lap pad down, and then second and third pads up. This is done blindly, so you're not going to see where you're putting that lap pad down around the bladder. You're simply going to feel down into this space and know where you're headed. Typically it's about 6 packs for adults, 4 packs for children. I've gone as low as 5 packs if they're a small, 4 or 5 packs if they're a small person. But once you get past sort of 8 packs, I start to worry that I haven't really closed down my pelvic volume in concert with my orthopods. And so if I'm putting in 10 or 12 packs, something has gone wrong. So usually you can get in 6 to 7 packs before you simply can't fit any more in. And I think this when you look at a CAT scan, you're really talking about this space that you see here in this inverted U around the bladder. And so, and here you can see at the time of unpacking, which is when you really actually can see the extent of this space. And when someone is learning how to do pelvic packing for the first time, I say, go in with your orthopods if they're plating the symphysis, get into so you can see where that space is and see what you're packing. Because if you've never seen it, and then I tell you to go dive into the bloody field and figure it out, it's a little bit harder. Versus if you see it here, you can really be like, oh, it's not that big of a space. It's around the bladder. This isn't so hard of a thing to do. And then after that, I close the fascia with a running monofilament. It's the one time I use a looped OPDS just because it's fast and I'm going to take this stitch back out, and then you staple the skin. I do think it is important to close the fascia to really effectuate tamponade. Some of our early cases, we were like, oh, we'll just close them quickly, close the layer up. It takes an extra 30 seconds and then staple the skin on top of that. Now, for those of you that want to sort of see one of these before you maybe are stuck doing it sometime, I had put on a video session at East. It's now been several years, but it's kind of nice to see it in action before you might have to do it yourself. I will say the case was a fairly classic one. A 24-year-old, his systolic was 50 in the emergency department. It remained in the 50s despite 3 units of red cells. His chest x-ray and his FAST were negative for other sources of blood loss. You can see the Reboa balloon up there. You can see that we've sheeted his pelvis is how we tend to bind the pelvis there. And you can see my penetrating towel clamp on the side of the sheet. And his systolic was still 70 to 80. The nice thing was I knew that I was giving this video lecture for East. And so I had a med student. I was like, okay, take my phone and just video it. So when you see the video, realize that it is some poor medical student who was suddenly thrusted my phone as we're in the operating room. But it was nice because it finally documented that this takes 5 minutes skin to skin. So there was a time lapse, and the actual packing component of it was 85 seconds. So putting packs in there was 85 seconds. There's more time making your skin incision, coming down through the fascia, et cetera. But it gives you a little bit of an idea of what pelvic packing is about. And do keep in mind that there's not as much blood loss because that Reboa balloon is still up when we're packing. So a good thing to know as well. Now, there are a couple of possible pitfalls when we talk about pelvic packing. Number one, it's really important to keep your spaces separate. So don't allow your pelvic hematoma to decompress into the abdomen by connecting your pelvic packing incision to your abdominal incision. So here you can see this is actually a pretty long pelvic packing incision early on in our experience, but it still is below the umbilicus, but we still kept that packing space separate from our X-lap. So I tend to keep all my X-lap incisions above the umbilicus and away from our pelvic space. You can also tell that this is the case in which I learned where to put my bar. So you see all those external pins sticking up. I had to hypothetically have the bars taken off because I wasn't ready to do all of this and had the bar right in the middle of my field. So my orthopods took the bars off and then came back and put them back on again. The other thing I would say is that if you have a patient who has a urethral injury or a bladder injury, this is the time that you can go ahead and decompress the bladder, but do it with a separate stab incision for your SP tube. Don't bring your suprapubic tube out through that midline because it just serves, as you can see in this lateral picture, as a focal point to allow egress of the pelvic hematoma through this little tract, which you wouldn't think, but sure enough, they can manage to bleed a significant amount out that tract. So bring it out through a separate stab incision and it goes a little bit better. And another key point, particularly as we talk about angioembolization, is that pelvic packing can be used in children. And this is a case of a 6-year-old that was run over by a bus very effectively. He obviously had complex fractures. Here you can see I've learned my lesson about where my bars are on my external fixator. He also had a urethral injury, and so he's got an SP tube. You can see the dressing now on his pelvic packing and his other external fixators elsewhere. So what are the indications for pelvic packing? And I'll go through this quickly. So this is our algorithm in Denver. So unstable patient, you do all the things that Toni mentioned, massive transfusion, you rule out a thoracic sore, and you do something to either sheet the pelvis and put an external or put a binder on the pelvis to close down that space. Fast exam is reliable in these patients. If it's positive, you're going to go to the operating room. If the patient stabilizes in the operating room after you address the spleen or the liver or the mesentery, whatever's bleeding, then that patient's going to go on to get resuscitated in the ICU and get scanned. However, if the patient remains unstable in the operating room and you look down from that supraumbilical X-lap incision and you see a pelvic hematoma, believe me, they're really big and obvious if you haven't seen them. If you see a pelvic hematoma, that's the patient that should go on at that point to get pelvic fixation and pelvic packing. Now, the other indication to pack a pelvis is in the patient who has gone down this pathway, they've gone into the negative fast exam. So you're not worried about a thoracic or an abdominal source at this point, but they've received 2 units of red cells in the trauma bay and you think it's due to a pelvic source. So no external signs of bleeding, no other bony injuries externally, and you're worried about a pelvic source. If they get 2 units and they stabilize, then that patient can go on to CT imaging and figure out the next step. However, if they remain unstable despite that transfusion, this is the patient that goes to the operating room and gets fixation and pelvic packing. And then we re-ultrasound the abdomen again, even though we've done it twice in the ED, we do it again in the operating room just to make sure we haven't missed anything. And we also usually do a chest x-ray as well to make sure we haven't missed anything in the chest or the abdomen while we're in the operating room. So 2 different pathways to get to pelvic packing. And I'll make a note, and I'm sure Joe's going to go through sort of the indications for angio-embo. This trigger point for us, the unstable patient despite red cell transfusion, is the same trigger point that we used for angio-embo 20 years ago before we started packing pelvises. People think that because I talk about pelvic packing that I'm anti angio-embo, which is actually not the case. I think it's complementary. But I think what's important is that in a rapidly decompensating patient, again, a very small minority of patients that you're talking about, this is what will stabilize the patient, even if they have arterial bleeding. What's nice is that then the pelvic packs allow you to figure out which patients need to go on for angio-embo versus those that simply had pelvic hemorrhage due to venous and bony sources. And it's about 13% of patients that go on for angiography. The problem is when we did our most recent evaluation, you can't predict this per se by any of these different measures. The only thing that really tells you whether or not the patient needs to go on is their red cell transfusion after they get to the ICU and their TEG has normalized. And so we simply keep track on our ICU doors, for lack of a better way of putting it, and we just count up how many red cells they've had since packing, and that's our indication for going on to angio. Here's our final algorithm. The other thing that will get you to angiography, if the patient remains unstable in the operating room, we worry then that they have an arterial source, and either our angiographers will come up or our vascular surgeons will come or if we have a REBOA up, we'll do a flush angiogram and determine that. Or as I mentioned, if that patient has ongoing transfusion requirements. So modern day analysis, I think, is always important when we talk about a newish, even though it's 20 years old, modality. In our evaluation of pelvic packing, and again, this is external fixation plus pelvic packing, about 21%. In comparative studies of equivalent patients in shock, there's a 32% mortality rate in the AAST study, a 41% mortality rate in an angio-only study, and a 37% mortality in a hemostatic resuscitation study. So lots of different modalities that are used, and this is the reason why we tend to default to pelvic packing. Quick touch on REBOA and its adjunct within XFIX and pelvic packing, always a great controversial conversation. We actually looked at the use of REBOA in our patients that underwent pelvic packing, and so here you'll see the breakdown of those with and without REBOA in 78 patients that had packing. ISS is higher in those that had a REBOA placed. No surprise, there is a trend, although not significant in this small group, of a lower blood pressure, a higher heart rate, and most importantly, the time in the emergency department was less in the REBOA group. So putting a REBOA in did not delay getting to packing, which I think is one of the biggest arguments that some people use against Reboa. So I think that we would argue that these were definitely more severely injured and received more red cells. We had 2 non-occlusive sheath complications, and replacement did not delay our intervention. Overall mortality in these patients, 14%. So we managed to take our original 30+ mortality rate to 22% with packing, and now down to 14% when we add Reboa into our algorithm. And that really, for us, I would say for me, I usually place a Reboa if their systolic remains between 60 and 70 despite red cell transfusion, if they're really down there pretty low. And then in general, I would just echo what Dr. McLaurin said. Use all of these techniques at your disposal. Binders, fixation, pelvic packing, angio-embo, Reboa, all of those are great tools in your toolbox. And that's it. Thank you so much.
Fantastic. Thank you, Dr. Burlew. That was a wonderful review. We'll move on to Dr. DuBose, who was able to join us. So welcome. He'll talk about Reboa and angioembolization.
Yes, thank you. I actually, ironically, was delayed by a bleeding pelvic fracture. I can tell you the punchline. I didn't have to do a Reboa or packing or any of that yet. So I got tasked, and I always hate following Dr. McLaurin and Dr. Burlew because they're much smarter than I am, and now you're stuck with the country surgeon. But I have been tasked with talking about the roles of angioembolization and Reboa in these patients. Both of the previous presenters have talked about how deadly these things can be and why we have tried to develop tools. This is the Constantini paper that Todd worked on in 2016 that showed pelvic fracture hypotension was associated with 32% mortality. So we still have a lot of work to do even up to 2016, and that work continues. These are the tools, right? You've heard a lot about them. I think any discerning trauma surgeon or trauma center probably has all or most of these in their toolkit with varying degrees of expertise and capability locally that they can use to identify algorithms to employ all of them. And the reality is none of these are done in isolation. I don't think I've ever done a Reboa with a lot of my Reboas end up with pelvic packing because you can't leave a balloon in the aorta forever. And external fixation is clearly a role, as is angioembolization. So a lot of these things end up used in tandem with each other. And there's really what we quibble about in the modern era is what order they should be in and what the toolkit readiness should be. And if you want a good review, you can see Dr. Burlew's been on this paper with us in 2021, which is not that long ago. We reviewed all kind of the state-of-the-art stuff. It's a pretty good review, I think. I'm not saying that because I helped organize the thing. Actually, all the other people on there actually wrote all the useful stuff. I just organized it. So let's talk about Reboa and angioembolization. These are the catheter-based hemorrhage control adjuncts, if you want to call them as such, that are utilized. And I think we have to start by recognizing that endovascular capabilities in the modern trauma care have clearly emerged in the last 20 to 15 years as important tools, but we also have to recognize they have limitations. And they also are associated with predictable potential complications. And that's where a lot of the debate, does the complication warrant the intervention? I would contend in the modern era that the complications have been managed and identified to such an extent that these should absolutely be part of everybody's toolkit. How they're employed in various institutions is relied upon by the expertise. There are also some fairly clear contraindications to use for pelvic embolization. If you have a clear anaphylactic life-threatening contrast allergy, that can give some pause, although we can do things like CO2 angiography in the modern era. If you don't have the capability, these are not the endovascular tools in particular, are not something that you want to watch a YouTube video and give a shot. I think that you need to have and acquire some training and some expertise. You have to have adequate vascular options. We have to get inside the blood vessel to be able to work inside the blood vessel or occlude inside the blood vessel. And in rare instances, that becomes a problem. And it's certainly at older ages with severe atherosclerotic disease and younger ages with very small vessels, that becomes something of an issue. And then patient instability with regards to angioembolization, which is part of the algorithm, but that takes time, as I'll mention in a moment, to muster those forces. So we need something like packing or Reboa or an X-Fix to stabilize the patient and control the hemorrhage until that can be brought to bear. The good news is the complications of endovascular technologies, I think at this point, are fairly predictable and avoidable. We know that there are what the access-related complications potentially are. We can manage them. The vast majority of them are not limb-threatening or life-threatening. And with appropriate team-based approach to these things, they can be managed. And remember, complications occur in living patients. So those things can be done and dealt with in patients that have survived their exsanguinating pelvic hemorrhage. We know that balloon positioning and inflation present issues if you do it in the wrong spot or in the wrong fashion. That's why training is so important. For ROBOA, the American College of Surgeons has a very nice course called the BEST course, run by Megan Brenner, that can provide trauma surgeons with some of these skill sets, at least initially. We know that if you leave any occlusion, be it a balloon or a clamp, long enough, you're going to get some occlusion issues and some tissue death potentially if it's really long, and certainly reperfusion issues as you reintroduce reperfusion to the area. And then sheath mismanagement, I think a lot of that is just education, and again, comes with adequate training. These are just some pictures. This is a very large pseudoaneurysm. Pseudoaneurysms are not life-threatening, but they can occur and cause significant problems if you stick too high. You can have problems that are retroperitoneal and can cause some issues if you have leakage from there. But if you have the right team put together, these can be managed. And again, they occur in patients who survive to have complications. Another article put together, very nice, by the BEST study group, talking about all the complications of ROBOA more specifically, but it touches on many of the endovascular complications and is a good review. Good news is it's not all doom days. These complications are not that common. In the most recent review that we've done using the aorta registry from the AAST, which captures all aortic occlusions, open and endovascular, pseudoaneurysm was really present with the modern low-profile devices very infrequently. Extremity ischemia was 1.2%, and balloon migration, which very rarely resulted in any adverse sequelae, was noted in 3.6%. What devices do we have? When I started using ROBOA, it was an old 12 French access port with a coda balloon that was massive, and you had to put it over a wire. There were about 3 or 4 more steps than the traditional process that is now presently employed. Subsequent devices have become all-inclusive, meaning that the wire is integrated, and the wire technology that facilitates placement is integrated into the shaft of the device itself. Some of them have monitoring capabilities. I'm not affiliated with either of the companies that make these two, which on the left is PryTime, and on the right is Frontline Medical, which is an even lower profile device. But these are the most commonly utilized in North American trauma centers by centers that employ them. And there's prescribed algorithms. This is an algorithm taken directly from the BEST course teaching milieu. You can see that where we place this balloon in the aorta to occlude proximal to the source of hemorrhage varies typically between zone 1 and zone 3. Zone 1 is in the descending aorta. If you have a positive FAST, that's something that can be employed. But for the sake of discussion here in the context of pelvic hemorrhage, zone 3 really below those renals. So the renals maintain perfusion. As long as we have the balloon above the source of pelvic hemorrhage, we're doing a pretty good job. So that needs to be placed adequately within the distal aorta. And here's an example of how this is placed. You can use prescribed distances from the femoral artery based upon some morphometric CT data that's available, and some of that's pushed forward by some of the manufacturers of the devices. You can use fluoroscopy. It's not mandatory. And many of these, we use extra anatomic markings, which is taught in the BEST course, to safely and effectively place these in the desired zone. And in this case, with the pelvic fracture on the left, it's zone 3 right above the iliac bifurcation in this unstable patient. So the question becomes, what do we do after inflation? If you can get a balloon in and occlude proximal to the source of bleeding in the distal aorta and occlude that pelvic hemorrhage, the key principles here, remember that this is a bridge. It has to be a bridge to something. A bridge to nowhere is a dark ravine that a patient can recover from. So you need to build a bridge to somewhere, and it's got to be to something. That something can be pelvic packing. That's something can be ex-fix. That something can be angioembolization. But they need to move somewhere. And I think that lesson has been learned, and Dr. Burlew's data showing that the patients at their institution at Denver who had ROBOA placed and moved very quickly out of the ER shows to me that we've learned that lesson very well. Those patients moved to an effective site in their hands for subsequent packing and then other interventions. And you got to continue to resuscitate. You have to remember that when you place a balloon in the aorta is occluded, and you have a massive reperfusion that is coming from that ischemia, even if everything works out well. So you have to be prepared to pay that perfusion back and deal with that reperfusion injury. There's lots of data, or I should say lots, there's several data sources. I'll touch on some at the end about ROBOA and use in pelvic trauma. This is by John Beanie, and it published an injury in 2022. It was an AAST aorta database pull from the first 5 years of the registry. And what they found at that point in time, we were really comparing the gold standard of aortic occlusion, which was either ED thoracotomy with a clamp on the aorta or a supraciliac clamp. And what we found was that Reboa patients treated with did better from a survival standpoint than those treated with the gold standard in the 30 years ago, which was simply cut their chest open and put a clamp on their aorta. So Reboa may have some promise. What we need to work out now is where the optimal selection for it is. I'm going to segue a little bit before coming back to kind of Reboa and a grouping of adjuncts to angioembolization. This is the classic kind of picture that you see. You see active extravasation in the pelvis. The devices we can use to get to this area are myriad and certainly require an adequate skill set to perform them. The things that we can put in the blood vessel once the hemorrhage is identified consist of permanent adjuncts like coils and plugs, temporary adjuncts including gel foam and a variety of liquid agents. And we can do this in a selective or non-selective fashion. When I say non-selective, you're basically occluding the internal iliac on that side and all the branches that feed the pelvis in that fashion. With the more selective angioembolization, you're getting as close to the source of bleeding so that you preserve that collateral flow, which can actually be quite important for your orthopedic colleagues who are then subsequently going to need to put that bone back together in some fashion. And when we rob them of that blood flow, we create, at least hypothetically, a situation in which they're going to have fracture malunion and issues with their repair. So something to think about. This embolization also has significant requirements. You need typically some antecedent imaging to see what you're going after. That can be done in the OR or hybrid suite with an angiogram, but a lot of centers require a CTA to demonstrate the bleeding that they're going after. You need readiness of an environment to do it in. You need either a hybrid OR or an IR environment, and you need to mobilize a team. Even at my own center, where I do my own, I'm a dual-trained trauma and vascular surgeon. I do my own angioembolizations of the pelvis when they're needed. I still have to get a machine turned on and the right technicians in there to bring me the right stuff. There is a delay and a time element that not all patients tolerate. And so Reboa or pelvic packing is very frequently, and external fixation are very frequently utilized in an antecedent fashion. So what do we know about this? We know that angioembolization can work for stable and unstable patients. This was a very recent study done in an Italian-based multi-center fashion. And you can see the technical and clinical success rates very high here. And interestingly, you would think unstable patients would be less likely to have success and more likely to have complications, but that appears not to be true. I think that we've now learned enough that if we can get the patient to an environment where we can initiate the procedure of angioembolization, the outcomes should be relatively the same for stable and unstable patients. It's getting the unstable patients there that's the challenge. How quickly do we need to move with angioembolization? Several studies have looked at this topic. This is a Japan study that found that with every 30-minute delay for embolization, there was an increased 30 to 24-hour mortality. Now, this is an active debate, and there's actually on the counter of that are other studies like this Devaney study that was published in the European Journal of Trauma in 2022. This was a single center study, but a lot of fractures and no patient exsanguinated despite times of angioembolization greater than 2 hours. But the caveat with looking at these timing issues in these studies is that, as we all know, patients who have more bleeding and are unstable are going to move quicker through the system, quicker to therapeutic intervention. And so the timing was probably influenced by the physiologic status, with sicker patients going quicker in this particular study. Does this overall benefit angioembolization? There are certainly people who say angioembolization, the benefit is potentially questionable in many patients. This was a meta-analysis that was done in 2022, 18 studies, 579 patients. And this one really compared preperitoneal packing to angioembolization, which I think is completely irrational in our modern understanding that these are complementary and not contradictory. But what they did find was that there was they were unable to make any conclusive comparison between the two because there's so much heterogeneity in how these things are employed. We don't have a data source that adequately captures the physiologic response to the initial resuscitation as an indication and subsequent response. And there's a lot of bias relative to centers and their capabilities that confound a really useful organization of a study in this fashion. And there's not a lot of well-established data on the very refined indications for angioembolization, particularly in the stable patients or the responders to resuscitation. The type of embolization used has never really been effectively compared in a head-to-head. Is it the temporary gel-based or the coils and plugs, which are more permanent solutions? We know that both are tolerated well, but is one better than the other in terms of ultimate outcomes? We don't know. The environment in which these things are done, should they be done in the interventional suite? and a formal hybrid OR. Or as we have at our own center and many others, they have a fluoro table and a vascular C-arm, which can convert a traditional open trauma OR into a vascular hybrid capable environment very quickly. Should we be doing these selective or non-selective? And then an interesting question about when you go in and do an angiogram in a patient who has a large pelvic hematoma but see no extravasation, is there utility in empiric embolization for those patients to avoid future bleeding? I don't think so, but that is certainly a discussion that's been based in many kind of topic scenarios. I will now kind of circle back to Reboa, but really as a manner of talking about both interventions, and not just those two interventions, but everything else the previous speakers have talked about. And Melike Harfouche, one of our moderators, put this together very nicely. She again used the AAST aorta registry. And what she did is she looked at the zone 3 Reboa utilizations in that registry. And this is one of the tables from that. And I'll tell you what I take away from this is that I don't think any Reboa is utilized in any institution that does not have a thoughtful approach to pelvic fractures and a process, a toolkit that's well developed, if you will. Reboa is not something that's commonly used in a haphazard fashion. It's part of a strategic process. And as with the data that was shown by both the previous speakers, if you have that process, you can get the majority of these patients out of the emergency department. Reboa alone is typically not a bridge to anywhere, but you will see it has been utilized in a minority of patients there on that right-hand box with a mortality of 35%. 2 hemostatic interventions were required in these patients after Reboa in 41, and you can see 30% there with a mortality of 41%, and in 26.5%, they required 3 interventions with a mortality of 30%. So there's a lot to unravel and a lot of things we don't understand about what order to use these things. What is the optimal order in which to break out the kitchen sink and use the toolkit that we have available to us? But clearly, we have the means in the modern era at most trauma centers to be able to provide a thoughtful approach based on our center's capabilities, our local expertise, to be able to get the most of these patients that we can to subsequent survival. You saw a couple of algorithms. The one from Denver was presented by a previous speaker. It's very effective. This is yet another algorithm that you can see here. And the interesting thing here is you see this zone 3 Reboa in the pink here with the hemodynamically unstable pelvic fracture. You see all these arrows, they don't go to one place first. You can see the angioembolization, pelvic packing, C-clamp, or external fixation. This is all where this branch point occurs right here at this inflection point, this pathway, and this branch in the stream, if you will, is dictated by so many things that we don't understand, but are largely at present dictated by local understanding, local processes, and maybe we have a means by which to better understand how these things play together and if there's an order that certain patients benefit from their utilization in. And as I would not be doing my job as the chair of the AAST Multi-Center Committee or a colleague of Dr. Harfouche without putting in a plug for this study, which I hope will help us answer some of those questions. The Hemorrhage Control Interventions and Pelvic Fracture Study under Dr. Harfouche's leadership is very actively accumulating patients. We still have the need for centers to participate. If anyone listening to this talk wants to participate, please reach out to Melike. But she's really going to capture a quite large number of these pelvic hypotensive patients and look at their pathway through the course across multiple centers. So this will be really the first since Dr. Constantini's observational review, which predated the use of Reboa and really the aggressive utilization of pelvic packing and other interventions. Now in the contemporary era, we'll finally have, I hope, some information that can help us refine the optimal use of the toolkit available to us for dealing with these very challenging patients. And with that, I will stop sharing and.
Wonderful. Thank you so much, Dr. DuBose. Thank you for the shout outs. This is clearly a topic that's very important to me, so I appreciate it. I will hand it over to Dr. Anandalwar, who will take us through the first case. Share.
Perfect. Thank you. And just an FYI that we'll go over about 15 minutes, but we really appreciate everyone's time, particularly our experts. So the first case-based questions that we wanted to ask our experts involves a case with a 67-year-old bicyclist versus truck. He was intubated at the scene, hypotensive on arrival with systolic blood pressures in the 50s to 60s. He was given whole blood and the MTP was started. His chest x-ray and EFAS were negative, and this is his pelvic x-ray to follow. And as you can see here, this patient has a vertical shear injury with superior displacement of his left hemipelvis. And so a few questions for our experts relating to this case. Dr. McLaurin, is a pelvic binder appropriate for this fracture pattern? We often fear that the application of a pelvic binder can make certain pelvic fractures worse, like lateral compression and vertical shear fractures. What are your thoughts on this and initial stabilization options?
Yeah, so that was actually a question that was asked in the Q&A as well. My answer to that is technically no, it's not appropriate. However, we put binders on our pelvis fracture patients just so that everyone sees, yes, this person has a pelvis fracture, and also knowing that these patients are going to be, if they're stable, that they're going to be in and out of the CT scanner and doing also, you're getting moves all over the place. So at least you put something on there just to give them a little bit of stability. But if it's recognized as a lateral compression or vertical shear, something like this, then just don't crank on the binder. But that's the main thing with this type of a pattern that we're always concerned about. And then also the other thing is sometimes people with really bad acetabular fractures get confused for pelvis fractures. Do not put a binder on an acetabular fracture because you're putting it around the greater trochanters and you're squeezing it. And so the trochanter is just going to shove the femoral head right into the pelvis. So please don't do that. If you see involvement of the acetabulum, do not do it, which can be confusing because if you go back one slide to your pelvis fracture there. So sometimes people will look at this and on the right side, you see that that's what we call a pubic root fracture. And there is actually probably a little bit of involvement of the acetabulum, but that's not the same thing as like a bad acetabular fracture that's going to migrate medially. So that's what you got to be aware of, the fact that pelvis fractures really high on the superior pubic ramus can start to look like an acetabular fracture. But as long as most of the articular surface of the acetabulum is intact, then that's still treated like a pelvis.
And I guess just as a follow-up, what are your recommendations for how long we should leave a pelvic binder in place? With how busy our services are, sometimes these patients keep getting rolled to the following days for their operative intervention. What are your thoughts about the length of time with the binder in place for these patients?
Yeah, so ideally it shouldn't be on for more than about 24 hours, 48 if you absolutely have to. And you need to do skin checks. And then also the other thing is, because usually it's stabilizing, but it's also stabilizing the clot. And so after 24 hours, you've dealt with that acute ongoing bleeding. But when you take a binder off, do it in a monitored setting and make sure, keep your eyeballs on the screen when you take the binder off. Don't be looking at the patient or looking around the room or checking your phone or whatever. As you loosen the binder, make sure you are watching the screen. And if you notice their blood pressure start to drop, put that thing back on.
Thank you very much. And I think for the sake of time, I might just put both the next two questions kind of together. Dr. DuBose, which patients do you recommend should get early femoral arterial access? Do you base it purely on their hemodynamic stability, or are there certain fracture patterns that make you want to get early access despite a patient being hemodynamically stable? I guess additionally, are there certain fracture patterns that make you concerned that there may be an associated vascular injury that would make femoral arterial access a little dangerous or require higher level training?
Yeah, great question. Obviously my vascular side of my brain can't do anything without access to the vascular system. And I often get tired of the blood pressure cuff cycles every 5 to 10 minutes or 3 minutes. That's madness to me. I mean, my blood pressure goes to 300 while I'm waiting to see what the next blood pressure is a half unit of blood. I like continuous data, especially if I'm going to the CT scanner, right? I'm thinking about moving that patient to that realm. So anybody who is hypotensive in my hands put a micropuncture in their groin. And the vast majority, 99%, that's all they get. They don't get any other things or stuff done. I like to see continuous data. Now the question about where to put it with the binder, you can do one of two things that I have employed. You can either cut a hole in the binder. There are some binders that are now coming online that have holes cut into them for that. Another thing that I will do is put a binder above and below. So as long as there's no major iliac wing fracture, and I'm watching Dr. McLaurin's face to make sure that I'm saying something she doesn't disagree with. But if there's no big iliac wing fracture, remember that what really drives the compression of as I understand it, of the open pelvic book is those femoral heads. That's your fulcrum, right? So What I do is I put up on the iliac wings and I put another binder down below to internally rotate those femoral heads to push that pelvis closed. And then I use that little sliver for my access is what I end up doing. And in some instances, like this one patient I had downstairs, I actually just stuck it in real quick while they were grabbing the binder because the patient didn't come with the binder. And then we secured underwears.
Thank you very much. I think we talked a little bit about these next two questions in our prior presentation, so I appreciate that. We can go to the next one. Dr. Burlew, for pelvic packing, what are your thoughts on the efficacy of it for arterial hemorrhage?
So believe it or not, it actually helps stabilize any patient, meaning whether it's venous or arterial in origin. And our 2017 study showed that you can actually delay safely angiography for up to 10 hours. So when we look at, it wasn't a matter of whether or not our angiographers were available, but we looked at patients and they actually didn't need to go for angiography if they had packs in place until the 10-hour mark on average. So the great thing about packing is it'll stabilize them and allow you to figure out who still has arterial hemorrhage, those 13%, or if you're in a facility that either doesn't have access, doesn't have components, needs time to set up, whatever it is, it'll stabilize the patient until you make a determination about whether or not you have the ability to do angioembo.
Thank you. And I guess as a follow-up to that too, for your pelvic packing, what are your endpoints for escalating intervention? For example, if you place 3 packs on each side and the patient hasn't really responded in the way that you would have hoped or expected, do you add more packs? Do you wait it out and correct the coagulopathy? Or is that your moment where you're trying to escalate to angioembolization?
Right. So once you start packing, I pack every patient, close them up, and then we pause. And we do those things. We recheck a fast exam just to make sure if the patient was so hypotensive in the ED that their fast exam ×2 was negative. You know, sometimes it takes a little while and a little bit of blood pressure for them to bleed into their abdomen. So we recheck a fast exam, we recheck a chest x-ray, make sure we didn't miss anything. And in that time to get those 2 interventions, another 15 minutes or so, that patient will either have responded to the resuscitation that anesthesia has ongoing, and we see another, another TEG, or we see another ABG, or different point of care measures that tell us whether or not that patient is stabilized. If that patient doesn't stabilize in that sort of reassessment period, that's when we go on to immediate angiography versus ongoing transfusion in the ICU is necessary, and then determine if they still need to go.
Thank you. And then finally, for Dr. DuBose, if we see contrast extravasation in a hemodynamically stable patient, what are your thoughts on whether we should intervene via angiography?
I think active extravasation always warrants a look. I think what you'll find many times, especially in the setting of a hematoma, is that they go back for diagnostic angiogram with ongoing resuscitation and FFP in the modern era, and the angiogram will be negative. But I think going to do the angiogram to see if that's the case. And then the beauty of a stable patient is now I can get as selective as I need to. So I don't upset doctor. If I want to go in and I want to embolize selectively, Dr. McLaurin's not come to me and say, why did you eliminate all of, yes, thumbs up. Why did you eliminate all of the blood vessel and vasculature that I need for fracture healing? So I think in my opinion, active CT of extravasation should undergo at least a diagnostic angiogram, and then probably a selective, if it's really seen and real, a selective angioembolization.
Perfect. Thank you all. And just to round out this case, you'll see here in this next slide here that the patient had active extravasation from both the right and left internal iliac arteries. During his course, a zone 3 Reboa was placed in the trauma bay with minimal improvement. It seems like they had maybe some difficulty with advancing it truly into zone 3. The patient also underwent pelvic packing, angiogram, and embolization of bilateral internal iliac arteries. Unfortunately, however, he expired shortly after his trip to the OR for profound shock and coagulopathy.
All right, I'm going to take us through case 2 in the next 10 minutes. We got a 60-year-old man who was pinned under a tractor for over 30 minutes. A pelvic binder was placed on scene, and he was normotensive en route, however, quickly became hypotensive upon arrival. Massive transfusion was initiated, and after 2 units, he stabilized. An EFAST was done, which was negative. X-rays were done as well, which I will show the pelvis shortly. There was blood at the urethral meatus, and a digital rectal exam was done, which also showed blood. Here's his pelvic x-ray here. And I'll quickly jump to Dr. McLaurin, any comments about this pelvic X-ray? Anything jump out at you?
I'm assuming that thing in the middle is his binder, correct?
Yes.
Yeah, so because this does not look like a terrible pelvis, but this guy was run over by a tractor. So I would think, tractor versus pelvis, the tractor is going to win. And that's the danger of this, that this looks fine. And so that's what you have to be careful of to understand what it is that you're looking at what point in time.
Great point. All right. I'm going to start off by asking Dr. Burlew, for this patient specifically with blooded urethral meatus, do you attempt a Foley catheter as kind of one attempt, or in this patient, would you go straight to a rug?
So I actually do sort of the most experienced person in the room, a one pass attempt. That said, I have seen Foley catheters put through that urethral transection into the pelvic hematoma. So if you get frank blood back, it could just be that you're evacuating the pelvic hematoma as well, just FYI. So don't presume that you're in the right place necessarily. But if you manage to traverse a partial transection and get urine back, then you don't have to sort of go do we do a rug? Do we just put an SP tube empirically in? You end up not in that. So I do a one shot, particularly in a stable patient.
And do you have any special tips and tricks for doing a rug?
Oh, I'm so not the person doing the rug, so I have no special tips or tricks. I hate to tell you.
Dr. DuBose, any thoughts on rugs?
I think you use a small catheter. You place it in the distal. You typically always, they're dudes like me, right? That's what we were the ones that have the long urethras and cause our problems with injuries. Tip of the penis, small catheter, gentle, flush through, and you're really just looking to see the urethra empty into the bladder. It's not particularly, the rug is not particularly rocket science. Almost said urethral science, but rocket science.
All right, Dr. McLaurin, what special orthopedic considerations are there in the setting of this kind of complex set of injuries, including your extraperitoneal bladder injury, particularly when you start talking about internal fixation? Would you even attempt that in a patient with an extraperitoneal bladder injury, urethral and rectal injuries? Any special considerations you have for these patients?
Right. So I want to do my internal fixation. Like if they're going in to repair the bladder at the time that the patient shows up, if anyone's doing an X-lap, if they're there, and assuming generally these are going to be APC fractures when you have these types of injuries, I'm going to fix it right then. That's as clean as it's ever going to be. Every time you go back, it's worse and worse and worse. And the last thing you want is a bunch of urine sitting there floating around, on your bones, and then you're going to open it up again and go back in and fix it. So ideally, if there is, a bladder injury, then I like to get in there and deal with it definitively early. And with a rectal injury, in terms of that, you just want to make sure that, if there's going to be a lot of soiling in the area, and especially if it's like an open fracture, you probably want to, from our standpoint, we would like you all to divert them because we don't want that stool in our orthopedic stuff.
And I wanted to touch on this question of how do you deal with an extraperitoneal bladder injury at the time of preperitoneal packing. Dr. Burlew, have you encountered this situation? How have you dealt with it?
So I think, again, there are very few patients that end up getting imaging in this milieu of diagnoses before they go to get pelvic packing. So the patient that's getting pelvic packing is the one that is unstable in the emergency department despite red cell transfusions. And so knowing whether or not they have an EP bladder injury is uncommon. They usually get packed, and then we figure out as they get imaged or unpacked and repeat imaged whether or not they have that injury. I can say that I have packed patients And they have then a diagnosis of an EP bladder injury, and I've even packed and then unpacked and then gotten the CT cysto and found the injury. So it's not a contraindication to me. That's simply a different a different injury that needs to be managed. But first we have to stop the bleeding. Otherwise, again, the whole goal is to decrease our mortality rate. Someone was sort of asking about, well, what about infectious things, or what about this? At some point, if we don't stop the bleeding in that first 12 to 24 hours, none of the rest of this makes a difference. Doesn't matter whether or not there's an increased rate of infection when, Toni wants to go put her hardware in. If we don't get them past that first 24 hours, they're not going to live long enough in order to get some of these complications, which is sort of a crass way of looking at it, but is kind of the truth. So no, I don't think it's contraindicated, and often you will not know whether or not they have a bladder injury at that time.
Great. All right, thank you. And I think we've kind of touched on this already briefly, but for rectal injuries, we're going to divert predominantly, but would either of you repair it at the same time as you divert it, Dr. DuBose or Dr. Burlew?
I think it's dictated by the hemodynamics and the status of the patient. What are the other injuries? How sick are they? Oftentimes just diversion and then coming back to fight that battle another day. It'd have to be fairly simple, but and then I really think it does take a thoughtful discussion with your orthopedic colleagues and what they need to do, because that you will do the best by the patient by determining how that repair influences what they need to do. And I think in the majority of cases where you see a bad pelvic fracture and a rectal injury, that conversation needs to take place, and we should defer to our orthopedic colleagues, because infected hardware is a nightmare to have to deal with.
And can I just put in a plug as well? When you're
Like a plug in the artery? Oh, sorry.
I guess I am talking about plugs. Yeah, when you put
I can
tubes
teach
in
you.
bladders and bringing things out of people's abdomens, if you could ask your orthopedic colleagues what their plans are, because these tubes always seem to be exactly where we want to make our incisions. So it would be really nice, not just for pelvis fracture, but also acetabular fractures, because you will get, sometimes injuries, the bone will kind of pop in and stab the bladder, or, have some sort of, other injuries related to the trauma. But anyway, it always seems like that the SP tube or the stoma or whatever is going on is right exactly where we want to operate. So it'd be, I encourage everyone to interact with your orthopedic colleagues and find out, what are your plans here, or what, even if you don't know your plans, what are some likely things that might be happening, so that, we can help each other.
Great.
Can I ask a question real quick to Dr. Burlew? How long do you leave your packing in?
I would leave it anywhere from 12 to 36 hours. So I basically wait, our very initial series back at the beginning in 2004, and our first sort of catchment, we recognized exactly what you said, which is that if you repack a pelvis because they have ongoing bleeding, then the infection rate skyrockets up to 50%. So for me, it's really important that the patient's coagulopathy and acidosis and hypothermia have all been corrected, and they've really physiologically been repleted before we take them back to unpack them. And then that procedure is done in concert with our orthopods. And it allows us that first 12 hours to have all these conversations that you mentioned. What do the orthopods need to do? Do we need to divert them? Do we need to do something else with our urologist, et cetera? And so then someone that has a rectal injury, for example, may actually be able to have a laparoscopic diverting loop colostomy done in a minimally invasive fashion, because they're no longer unstable and will be far removed from whatever our orthopods want to do. So we really make sure they're physiologically improved and stable before we take them back to take those packs out.
Thank you.
And last but not least, I wanted to touch on this feared and rare open pelvic fracture, where you have hemorrhage from the vagina, soft tissues, even rectum, and you really can't rely on that tamponade. Dr. DuBose, any thoughts on this patient? How is this an embolization priority?
Well, I think certainly most of those will have a CT, and you'll see some extrav or not extrav, right? And then you have to determine, is this hematoma evacuating out, or is this active hemorrhage if it's bright red stuff? I think angioembolization, or at least a diagnostic angio, doesn't hurt anything in terms of defining options. And it's one of those cases where you can circle the wagons with all the specialists and say, hey, I'm about to squirt the angiogram in room 13. Dr. Burlew, you want to come take a look? Dr. McLaurin, come take a look. Or urology, come take a look. And let's talk about what I see and what I'm likely to have to take out in the distal distribution of the arterial supply that's going to be affected. But the big thing, as Dr. Burlew said, you got to control the bleeding, right? At the end of the day, nothing else happens. The reason the complication rates are so great in a lot of these patients is because they don't survive to accumulate them. So that is those are painful battles, but they're battles that we are trained and destined to fight, because we are getting more and more of these patients, not only out of the ED, but out of the OR and out of the ICU. So.
Well, I think it's also really important to recognize that an open fracture doesn't mean you can't pack the pelvis. So even though the book chapter says it's a contraindication and that it doesn't work, which is always a good lesson to learn of like, that doesn't sound right. Like go study it, go prove whoever said it wrong, which is exactly what we did. So open for us, you can still pack a pelvis very effectively. The open pelvic fractures get more transfusions. They get almost double the transfusions, but it is still effective. And the mortality rate in those open fractures drops from the 50% level that Dr. McLaurin mentioned earlier, drops to below 10%. So you can still go pack the pelvis. And then you have to, in addition to doing, calling Joe to come do his angio, because I think that's important, but then you also just need to do local control. You saw that obviously that big open pelvic fracture in my Reboa slide, right? Where it was just clearly bleeding all over the place from this big external gloving injury. You have to pack that entire space, and really sometimes I'll tape the legs together to try and effectuate tamponade of that perineal space, but you have to actually get into that perineal space and tightly pack it, and then put binder, close their legs together, anything that you can do in order to control the bleeding that's externally lost. But the packing, remember, those spaces don't necessarily connect, so you can still pack them.
Yeah,
And if
also
it's
don't
external
be
bleeding, you can pack the pelvis, the vagina and the rectum. Those are
Yep.
things you can pack, right? So
Yeah. That's exactly what I was going to say. Don't be afraid to pack the vagina. And, everyone's always worried about, infection, vaginal packing. Again, if they don't survive, it doesn't matter. So do whatever you need to do initially, and then we deal with it later.
Fantastic. Thank you all so much. I'm just going to jump through all of this. The patient did very well. Thank you all so much. Thank you, Dr. Burlew. Thank you, Dr. DuBose. Thank you, Dr. McLaurin. Fantastic presentations. And thank you, Dr. Anandalwar, for co-moderating with me. And thank you to the AAST and Caitlin Sanders for their help. So the next Grand Rounds is on May 15th, and it'll be with the Prevention, Geriatrics, and ACS committees. Thank you for participating.